have the pleasure to talk about Occult Tethered Cord, and I want to present our recent findings about how it is a distinct clinical entity, and I'd like to propose the concept of it being a reversible clinical syndrome. So in addition to my financial disclosures, I'd like to also disclose that I've been very heavily involved in also understanding the concept and the condition of another occult disease, which is idiopathic normal pressure hydrocephalus, which was actually coined in the past as occult dementia, because no one could really understand how in the presence of just enlargement of the brain ventricles, such a disaster in the brain can occur with dementia, gait instability, and urinary incontinence. And it was also deemed as an occult condition. And that's kind of what we're seeing also with the occult tethered cord, where we have a clinical syndrome that presents with symptoms of what we usually consider tethered cord symptoms, but it's in the absence of any or maybe just little radiographic evidence. So we can translate the understanding of like a syndromatic concept that is not backed up by any evidence, and that it is the more important that we define its clinical presentation and also the reversibility and also predictability of an intervention that we can do for a syndrome that is otherwise occult. So my objectives and basically also my take-home message for today that I'd like to present at the beginning is that occult tethered cord and occult tethered cord syndrome probably is a very unique and distinct clinical entity that might be singled out a little bit out of the realm of tethered cord syndromes. And when we looked at our neurological presentation and the neurological findings in our patient population, it actually presents as a very distinct upper motor neuron dysfunction, plus the conus dysfunction. And we found in our data that a constellation of leg, back pain, combined with the conus dysfunction and leg spasticity and leg fatigue on the neurological exam has shown in this symptom package an 89% improvement of those signs and symptoms at the 3 months mark, and still maintained clinical improvement at the 12 months mark in 70% of patients. So this symptomatic constellation has been very responsive to the surgical intervention of the cord release. And it may be that the symptom scale that can be created out of those symptoms had shown higher odds of surgical improvement and was able to accurately predict outcome of patients in 83%. So I'm gonna go a little bit into the data. First of all, of course, you know, we do understand the triad of tethered cord syndrome, and I have lectured about that many times. And the triad is something that is a hallmark of the tethered cord syndrome. And needless to tell this audience, but just to summarize, that the symptoms in the realm of neurological complaints are, of course, different depending on the ages. Infants, it's decreased leg movements, absent reflexes. As we go older, we have more signs of spasticity, hyperreflexia, and pain, sometimes asymmetrical motor dysfunction. The urological realm, of course, is the neurogenic bladder with bladder retention or frequent urinary tract infection due to the retention. And then the orthopedic realm is the scoliosis or other skeletal deformities, or sometimes even delayed growth or plateau in growth. But we have to remind ourselves that these are symptoms, and the syndromic constellation has been identified based on the classical radiographic evidence cases like low-lying conus, as shown here on the MRI, or a fatty phylum, as shown on the MRIs. But how, of course, can we explain those symptoms occur in the absence of a low-lying conus and in the absence of any pathology in the spinal cord? And before I go into the syndromes, I just wanted to mention here again, and I talked about that last year at this conference, that we have established some understanding of how a phylum can affect the spinal cord and can still put pressure and strain on the spinal cord, even if there's no low-lying conus or no evidence of phylum pathology. And we published this a year ago in World Neurosurgery with the title coined as a diseased phylum terminale as a cause of tethered cord syndrome in Ehlers-Danlos. And of course, these patients usually present with an occult scenario where we don't see any evidence in the radiographic portion. And I kind of like this picture here where we see like a car on the left on the bumpy ride if the shock absorber of the car is dysfunct. And the same, probably is true for the phylum terminale. If we have a diseased phylum terminale, let it be too inelastic or too lax, it fails its capacity to buffer stress and strain, and it also fails in the suspension or elastic suspension of the spinal cord. And the phylum is our only vertical suspension ligament, and so it's supposed to be a very important suspension ligament. But in the disease situation, it probably doesn't matter how long, how short the phylum is. It causes abnormal suspension of the spinal cord and would cause a spinal cord motion dysfunction. And that gets maybe our spinal cord into a very bumpy ride. So that is a concept that we proposed. And in the bottom picture, you see the phylum almost like a inelastic stick pulsating with the CSF pulsations when opening the dura for a tethered cord release. So we did testing of the phylum elasticity to get a little bit of a proof, that the phylum in fact fails in the elastic suspension of the spinal cord. And you can see here, like on the bottom, I hope you see my little arrow. You can see here, this is the phylum terminale, just came out fresh of surgery that we sent to the Brown lab, where it was, clamped. And we did stress and strain tests to see, is there in fact a loss of stress and strain buffer capacity? And we could actually see that not only in people with Ehlers-Danlos syndrome, where you usually think of laxity and plasticity or hyperplasticity of tissues, we could also see it in the tethered cord patients without EDS. So this is a lot of biomechanics, but those biomechanics really had helped us to understand that the phylum fails with buffering plastic strain. Here in the upper right corner, you see that a good ligament, and let's say the phylum is a ligament, a suspension ligament, a good ligament is capable to buffer stress and strain up to 8% increase of its length. This is from muscle tendons. And when we look at our stress and strain profile that we saw in the tethered cord phylums, you can see here that we already lose the capacity of elastic buffering already at like 4% of strain. And in people with hypermobile EDS, as you can see here with the red line, it's even lost, like there is no linear relationship at all between stress and strain, meaning that phylum has no capacity at all to adjust or buffer any stress and strain. And these are all occult phylums. And you would say, well, how would a normal phylum look like? Well, the other graph here shows you a phylum of a cadaver where that cadaver apparently had not, like, at least not known, tethered cord syndrome, you can see a phylum that, oops, sorry about that, a phylum that is supposedly healthy can buffer stress and strain up to 8%, but our tethered cord phylums are losing it already less than 5%. So that shows that our phylum can fail even in the setting of not being too short, or in the radiographic setting of occult. And then, of course, this I have shown many times, shows that in EDS, it is probably mainly due to collagen failure, and the collagen fibrils are all disheveled, swollen, screwed, corkscrewed, meaning that they are degenerated and that they are no longer integrated into a regular pattern of collagen bundles. And this is a phylum in a person without EDS, where the collagen fibrils look more healthy. And we also found inflammation in the phylum, which also causes certainly elasticity loss and abnormal structure of the phylum. So, of course, this is more, that's just a backup or the background that there is biomechanic proof that the phylum, in fact, fails in tethered cord in its biomechanical capacity. So how do we clinically approach this? Bringing the evidence biodynamically that a phylum can be diseased is one thing, but we also need the clinical approach to be able to accurately diagnose the person, and also to prove the evidence of that the symptoms are reversible or salvageable when we offer surgery. So a lot of text, but I walk us through this. So we basically, starting 2017, we started a prospective observational study where we looked at patients that underwent tethered cord surgery for occult tethered cord. And we followed them 3 to 12 months from surgery, and we only completed those patients that had complete follow-up, and these were 145 patients. And we applied a very comprehensive symptoms questionnaire where we basically ask every symptom from head to toe, left to right, strength, sensation, pain, very comprehensive. And then we looked at those patients that went into our clinic, of course, with tethered cord syndrome, leg pain, back pain, urinary and bowel incontinence, lower extremity neurological symptoms. These were included. And then we mandated clinical progression up to 6 months. We excluded non-neurogenic bladder dysfunction by a urologist, and also, of course, the MRI should not show a low-lying conus or any other pathology. That is very important. We usually mandated, of course, a clean slate spine MRI because we wanted to exclude low-lying conus or any other pathologies like a spinal stenosis or MS or other tetherings that could potentially explain the symptoms. So true radiographic absence of anything, basically. So then these are some results of the patients. What is very important is that often, like the motor function was 4 out of 5 of 4 out of 5 or 5 out of 5 in most of the cases. So if we apply our medical research council scale, the patients do well on clinical exam. But what is important, they still all complain about the leg fatigue, but the leg fatigue usually comes with walking or standing. So the formal clinical assessment is not really like getting us to the fatigue mode of dysfunction, I'd like to say, what we usually see in those patients. And those patients that had 2 out of 5 or 3 out of 5 grade strengths are usually those patients that had a medical history that explains the paresis from, like from childhood or other comorbidities that they were suffering from, or CRPS. And also what's very important, that the symptoms fluctuate. They're often one day more on one leg and the other day in the other leg. They are also often asymmetric with more pronounced foundings and weakness in one leg. So there usually is one leg that is more symptomatic than the other, and symptoms are very spotty and irregularly distributed, which certainly is not a radicular pain pattern. And sometimes that makes it difficult to catch it. But here, like in this sensory pattern and this asymmetric distribution, here certainly comes the neurological finding of the upper motor neuron disease, which I want to present in my next slide. But just real quick, of course, the conus dysfunction is supported by the urodynamic studies. And in our paper that we published in World Neurosurgery a year ago, we did certainly find the classic detrusor sphincter dyssynergia in 50% of patients, but some patients also had neurogenic increased bladder capacity with decreased sensation when emptying the bladder. And sometimes there was also decreased bladder capacity, not only increased bladder capacity. And of course, in 9% of patients, there's also stress incontinence. So there is a mixed pattern of urological findings as evidenced by the UDS that is not always the classical detrusor sphincter dyssynergia. So we should be a little bit more inclusive also of other findings, as long as there is no structural failure of the bladder itself. So this is, like the result of our comprehensive questionnaire, where we looked at the most prevalent patient-reported symptoms and clinician-reported findings in the realm of the triad. This is the neurological triad, the neurological element, pain, and continence. And you can see here the most prevalent findings in the neurological symptoms is lag fatigue and lag paresthesia, and increased muscle tone in the legs, hyperreflexia in the lower extremities, and a clonus in the foot was also found with high prevalence based on the neurological exam. The pain, the top 5 were leg pain, sacral pain, lower back pain, cramps in leg and back, and fluctuating pain symptoms, alternating from one leg to the other. And the pain was usually like an achy, like deep pain, a soreness feeling. And then the continence scale, the leakage, urgency, frequency, hesitation, and bowel symptoms. So each one of those the top 5 neurological items in each of the 3 elements were given 1 score. Certainly we could have scored them with different weight, but we gave them just 1 score. And then we looked at, like, okay, how do those or top 5 items in each of the scale or in the entire scale, or 15-item scale, do on follow-up? And you can see here on the box plot, the entire improvement for the entire 15-item scale shows quite a drop from a mean score of 9 to a mean score of 3. And then, of course, it jumps up again a little bit at the 1-year mark, where we do see that certainly some symptoms reoccur, and certainly other factors weigh in. And we assume that the main effect on the combined scale is that pain has the most variation in terms of like how it evolves after surgery. Unfortunately, the pain scale or the pain assessment shows a great variation at the 12 months visit, which is shown here, probably to other comorbidities and pain. Of course, we had 60% of patients who had the diagnosis of connective tissue disorders, where we also have other pain factored in. The limitation is here that we just asked for the quality of the pain, and we really didn't apply any standardized pain scales. But the follow-up of the neurological symptoms looks pretty good. The drop is from a 3-point to a 1-point score, just one neurological symptoms on the 15-item scale, and also continence looks pretty good, with a significant drop at 3 months and some recurrence at the 3 months mark. The statistics are shown here. This is highly statistically significant in a multivariate analysis. So how does that scale help us to potentially also not only apply follow-up assessment, but also allow us to predict surgical outcome? And we did a very simplistic analysis. We said, okay, a responder is a person that shows one increase in 1 point in the scale, which is certainly not the fairest way to separate two groups. But the blue bars is the portion of the responders that increased by 1 point in the scale, and the red bars are no responders that didn't show any change. And you can see here, that the higher you were on your preoperative scale score, the more likely you were a responder. So you can see here, above a scale score preoperatively of 6, you see a lot of responders here in this relation to the preoperative pain score. This is after 3 months, and then also after 12 months. If you had a scale score more than 7 preoperatively, you were still very likely to be in the high responder proportion at the 12 months mark of surgery. And this is using the logistic regression. You can see here, if you have a scale score F7 before surgery, your probability of being a responder is 60%. It goes up to 80% with a score of 9, and almost up to 90% with a score of 11. So the higher you are, affected in that score, the more likely it is to improve. And then the receiver operating characteristic shows also a high accuracy value of predicting accurate outcome with a value of 83%. So the outcome was not really affected by the presence of scoliosis or the presence of a connective tissue disorder. Neurocutaneous signs were not very predictive, but certainly our Triad components, pain, continence, neurology, were very predictive of the outcome. This is more to show you that the other factors did not affect any of the outcome potential. So with that, I like to conclude that we have a distinct, or we discovered a distinct clinical element in patients presenting with occult tethered cord, which exhibits clinically lower back pain and leg pain, which is substantiated by the neurological finding of hyperreflexia, foot clonus, increased muscle tone, and leg fatigue, which is pretty much consistent with an upper motor neuron dysfunction, of course, plus the conus medullaris syndrome that is substantiated by the urodynamic findings or the neurological symptoms. So the upper motor neuron dysfunction obtained on the exam is probably very crucial for the accurate diagnosis, but not only the diagnosis and establishing the symptom, but also for the prediction of the outcome. If you rate those symptoms based on a symptom-based scale that we introduced. This is, of course, all in the radiographic absence of pathological findings on the MRI. So it should not be explained otherwise. If you have a myelopathy or spinal stenosis, it can be a problem. And it's difficult to establish the diagnosis. So the data strongly indicate that a combination of neurological, continence, and pain syndromes play a central role in diagnosis, and the scale probably offers valuable insights into the outcomes of phylum resection. Thank you so much, and thanks for listening.
Okay, since Dr. Klinge, since you're on Zoom, we'll take some questions. So anybody have any questions, just raise your hand and we'll get a microphone over to you. There's one over there in the back.
So I have tethered spine, and I also have syringomyelia from C4 to T12. How does it start to impact your vision? So mine is starting to impact my vision, like my pupils will often not be the same size, or I will be unable to see without covering one eye. So how does it start to impact vision?
Do you hear me?
Yes.
So, of course, it is not easy to make a direct correlation of how tethered cord can impair the vision. I know my answer now might disturb some of the physicians in the room because it's a long stretch that I'm trying to make. But let me say this. I presented to you our biodynamic findings. Remember when I showed you that car where the phylum losing the capacity to buffer stress and strain, it acts as a bad shock absorber, and you can argue that those shocks are also applied to the spinal fluid circulation. Our spinal cord is bathed in spinal fluid, so you might also affect, the damper system in our body, and the damper system is the spinal fluid. So I would argue that tethered cord can also affect the spinal fluid circulation and the dampening function of the spinal fluid. And of course, since our optic nerve is also involved in the absorption of spinal fluid, it might have a effect also in our spinal fluid absorption. And that might also be the cause why so many people complain about blurry vision, pressure in the eyes, and vision problems. And particularly with syringomyelia, you probably have more of a CSF circulation problem that might, be from tethered cord, but also along your spinal canal. So that is probably a spinal fluid pressure problem, if I can say that.
Thank you so much.
Another question? Go ahead.
Hello.
Hello.
I wanted to ask what the success rate is for untethering or tethered cords with type 1 split cord. So diastematomyelia and also syringomyelia.
Yeah, of course, at least my experience is that in my professional opinion, the split cord malformation type 1 or type 2 provide a very significant pathology where so far I haven't seen very promising results because it must be that not only the split cord malformation, but also having a long-standing problem with split cord malformation, where the spinal cord is really affected by most significant tethering, causes the most significant damage to the neural tissue and the spinal cord. Let alone the pain, but also the upper motor neuron dysfunction is even worse. Those patients usually, have even sometimes worse spasticity and motor neuron problems after the surgery. So the results are not very promising. It must be from that this is the most significant and severe form of tethering. Particularly in the adults, the results are not very favorable, unfortunately. I wish we could do better.
Thank you.
Any other questions? Oh, it looks like we're good. Okay, thank you, Dr. Klinge. I appreciate you coming online and presenting.
Thank you so much. Have a good meeting and a great conference. Sorry I miss you.